Hi, this is Nurse Elise. I'm calling from the med-surg floor to give you a report on the patient that you will be assuming care for. The situation is that Hector Gomez is a 68-year-old male. He is in room 1. His doctors are Robert Peets and Dr. Simmons. His medical diagnosis is pneumonia and a COPD exacerbation. He is allergic to ampicillin, and his precautions are fall risks. He was NPO but is now on a soft diet, and he is on INOs. Are you familiar with this patient? Since you're not familiar, I'm going to give you some background. I've been unable to obtain a past medical history, but the events leading to the hospitalization was that his daughter found him alone on the floor, and she's expressed concern about his drinking and smoking habits. Since he has been hospitalized, Mr. Gomez has been found unresponsive during my shift and consistently asks for a higher oxygen therapy. He has a left thoracentesis and pleural fluid study with a chest tube, 20 centimeters water seal drain. His latest vitals were temperature 100, pulse 110, respirations 30, blood pressure 138/90, and oxygen saturation was at 91% on 2 liters via nasal cannula. When he was admitted, his blood alcohol concentration was 20 milligrams per deciliter. His CBC red blood cells 4.8. Hemoglobin was low at 9.3. Hematocrit was low at 29%. White blood cells were elevated at 13,000, and platelets were normal at 162,000. His blood chemistry came back. Sodium, potassium, chloride, calcium, creatinine, and ALT were all within normal limits, but his phosphorus was high at 5.5, his BUN was high at 2.2, his blood glucose was high at 180, his AST was high at 45, his cholesterol was high at 225, his albumin and prealbumin were both low at 3.0 and 17. His ABGs read pH acidic at 7.3. His PaO2 was low at 80. His PaCO2 was high at 54, and his PaCO3 was low at 19. And his oxygen saturation was at 88% when he was on room air. His urinalysis came back clear, yellow, normal odor. Specific gravity was at 1.002, and the pH was 5.8. It was negative for proteins, ketones, glucose, red blood cells, white blood cells, bacteria, casts, and crystals. He had a sputum culture done, which was positive for streptococci and staphylococci, but was negative for blood. He had a chest x-ray yesterday with notable hyperinflation of bilateral lung sounds and a flattened diaphragm. Changes are characteristic of atelectasis and bilateral in the bases. The abnormal chest density is present in the lung left base and was suspicious of pneumonia. Today, his chest x-ray showed extensive left side pleural effusion noted in the left lower lung, and this is a marked change from yesterday's x-ray, but there is still hyperinflation in the bilateral lung fields, and the atelectasis in the right side persists. His scheduled medications include levofloxacin 750 milligrams IV bolus daily over 120 minutes, nicotine 21 milligrams topical daily, prednisone 10 milligrams IV bolus every 12 hours, salmeterol 1 inhalation every 12 hours, albuterol 125 milligrams per 3 milliliters of normal saline via nebulizer every 4 hours, 9% sodium chloride 3 milliliters IV bolus via normal saline lock every 12 hours. He has orders for PRN medications as well. Acetaminophen 650 milligrams PO every 4 hours needed for pain. 0.9% sodium chloride 3 milliliters IV bolus via saline lock. And diphenhydramine 25 milligrams PO every 6 hours for itch. And for my assessments, he was alert and oriented ×3 at the beginning of my shift, but now says that he's too tired to answer any questions. Cardiac assessment included sinus tachycardia, but I believe that is related to a COPD. His pulses were strong and palpable bilaterally, approximately 3+. Respirations, there's crackles and wheezing noted bilaterally, and dullness at the lower left lung field. There is nothing clinically significant about his GI system. However, because he has been moved to a soft diet, I would recommend assessing that. He has adequate urinary output every day, about 300 milliliters every hour. He is in an increased risk for skin breakdown related to alcohol consumption, limited mobility, history of corticosteroid use, and chronic illness like COPD. His diet is soft, and I would recommend increasing his protein. He is on INOs, and he has a saline lock in his left hand. My recommendations for your shift are to follow up with some assessment findings. His ABGs pointed towards respiratory acidosis, so I think that some ECG lines should be run due to the risk for ventricular fibrillation related to the hyperkalemia from the compensation. Assess his lung fields again. He also experienced an allergic reaction to the antibiotics during my shift, so I would assess how well the Benadryl is working for him and contact the provider about new antibiotic orders. Some lab tests that should be scheduled for the next shift, again, the ABGs, and I also think it would be important to assess renal function. And orders for the next shift include following up how well the nicotine patch is working for him, vitals every 4 hours, and blood sugar tests really only need to be done in the morning because his urine analysis doesn't point towards diabetes. And some safety issues. I think a major focus for your shift should be those psychosocial and educational needs. He continuously asked for an increase in his oxygen therapy during my shift, so I think it would be really important for you to reinforce client education on why his oxygen shouldn't be set higher with his COPD. I think it would also be important to do a CAGE questionnaire about his drinking habits, and there is a flow chart with very brief advice on smoking, and it assesses his willingness to quit smoking or make a referral for his follow-up. I would also like to get a social worker involved because his daughter expressed that she was nervous about him living alone. He was also found on the floor. And along with that, I think a 6-minute walk test with a respiratory or physical therapist would also be important to see if he can physically be on his own, and to also assess his ADLs. Do you have any questions?